Hello, my name is Zach Knoll, and I'm an assistant professor at the University of Maryland School of Pharmacy and a clinical pharmacy specialist in cardiology at the University of Maryland Medical Center. It's my pleasure to talk with you today about aortic valve stenosis, also referred to simply as aortic stenosis or AS. In order to truly appreciate the clinical implications of AS, it's important to have a good understanding of the anatomy and physiology of the aortic valve, or AV. The AV is a semilunar tricuspid valve that separates the left ventricle and the aorta from each other. As depicted here, the size of the aortic valve is comparable to that of a quarter. When the valve is open, the orifice area is approximately the size of a nickel, or 3 to 4 centimeters squared. Note that just above the right and left leaflets of the aortic valve lie the openings of the right and left coronary arteries, which fill with blood during diastole. The aortic valve serves to allow forward blood flow to the systemic vasculature during systole, while preventing backward blood flow into the left ventricle during diastole. As depicted in this second picture, the leaflets open and allow blood to move from an area of high pressure, the left ventricle, to an area of lower pressure, the aorta, during systole. Once the pressure in the aorta exceeds that of the left ventricle, as is the case in diastole, the leaflets of the aortic valve will rapidly close and prevent backflow of blood into the left ventricle. Now that we have an understanding and appreciation for the role and function of the aortic valve, let's begin talking about aortic stenosis. Aortic valve stenosis is a disease characterized by narrowing of the aortic valve. Such narrowing leads to obstruction of outward blood flow from the left ventricle and eventually leads to cardiovascular collapse owing to left ventricular failure. What I've shown here is a picture of two aortic valves. If you recall, the aortic valve is normally tri-leaflet in nature. Patients with a congenital heart defect resulting in only two leaflets, termed bicuspid aortic valve, are at high risk of developing AS in their lifetime. Indeed, the most common cause of AS requiring aortic valve replacement in patients under 65 years old is bicuspid aortic valve. The second valve is actually just a typical tri-leaflet valve. However, in patients with risk factors such as hyperlipidemia, diabetes, or history of smoking, the valve is at risk for degenerating into AS. In patients with these risk factors, calcification can form along the base, or also termed the annulus, of the aortic valve. Such calcification is normal with aging and does not impact patient hemodynamics. However, if the calcification begins to extend beyond the base and to the leaflets of the valve motion can become encumbered, and the valve does not properly open, effectively reducing the aortic valve area. In other words, the orifice area for blood leaving the left ventricle becomes substantially smaller owing to the reduced mobility of the leaflets in the aortic valve. As demonstrated in this last picture, the effective valve area can be reduced to the size of approximately the circumference of an eraser on the end of a pencil. This has significant hemodynamic consequences, as we'll talk about later. Although this process can occur over the course of decades, once the calcification of these leaflets begins, a more rapid decline in hemodynamics is observed. There are three main identifiable causes of AS. Congenital abnormalities, such as bicuspid aortic valve, are relatively common causes of AS in younger individuals. However, the overall incidence of this is low. A second cause of AS is rheumatic fever. As you might imagine, this is much less common in the United States than in underdeveloped countries. Often AS secondary to rheumatic heart disease is accompanied by mitral valve stenosis. Lastly, the most common cause of aortic stenosis is age-related calcific AS, also known as degenerative AS. This form of AS is most commonly seen in patients over 65 years old and increases steadily with advancing age. It is characterized by extensive calcifications that develop on the aortic valve and hinder leaflet motion, as previously discussed. This diagram outlines the progressive nature of AS and contributing factors for the development of it. As you can see, there are several comorbidities commonly associated with atherosclerotic cardiovascular disease that are also a risk factor for developing AS, including diabetes, hyperlipidemia, smoking, hypertension, etc. All of these processes contribute to an inflammatory response that smolders within the valve and may eventually lead to progressive AS. As you can see, only about 15% of patients with aortic sclerosis will go on to develop aortic stenosis. Once progressive AS develops, however, nearly all patients will develop severe AS with time. You can also see how rapid leaflet calcification occurs once AS has developed, as depicted here by this bold red line. It's an exponential increase in leaflet calcification as the disease progresses and as patients age. With these pathologic changes in the aortic valve comes some significant hemodynamic changes. A greater amount of pressure is required in the left ventricle to overcome the gradient across the aortic valve, also referred to as the transvalvular gradient. In compensation, the left ventricle becomes hypertrophied. In response to this hypertrophied, stiff left ventricle, the left atrium also enlarges. This picture demonstrates the enlargement of the left atrium, almost a ballooning-like effect that we see with it, as well as the thick left ventricle as a result of the increasing left ventricular pressure. All in all, these compensatory mechanisms are designed to maintain cardiac output. However, as the disease progresses and as the effective aortic valve area diminishes, cardiac output begins to decline. As a result, we see a reduction in myocardial and cerebral perfusion, and ultimately see reduced left ventricular contractile function, as well as increases in pulmonary venous pressure, which can ultimately impact the right side of the heart as well. Most patients with AS are asymptomatic until the latter stages of the disease. The most frequent complications that prompt patients to seek medical attention are angina as the result of decreased myocardial perfusion and syncope as the result of decreased cerebral perfusion. Syncope can be attributed to an inability to increase cardiac output across the narrow orifice of the aortic valve. An inability to adapt to acute reductions in peripheral vascular resistance because of this fixed cardiac output makes patients with severe AS particularly prone to syncope due to orthostatic hypotension. Lastly, patients can present with heart failure symptoms as they progress throughout the disease and develop left ventricular failure. In addition to the aforementioned complications, atrial fibrillation frequently develops in severe AS due to left atrial enlargement that occurs. This is a particularly grim prognosis for patients if surgical treatment is not soon pursued. The left ventricle relies heavily on preload to overcome the transvalvular gradient, and as such, a loss in atrial kick can profoundly impact the patient's symptoms and clinical status. Lastly, a phenomenon known as Hyde syndrome can occur because of microvascular changes within the gut, as well as acquired von Willebrand's deficiency, ultimately leading to an increased risk of gastrointestinal bleeding in patients with severe AS. Under normal circumstances, the velocity of blood entering the aorta is approximately 1 meter per second. With severe AS, the velocity increases to greater than 4 meters per second. As you can imagine, this increase in velocity introduces turbulence and shear stress to the various blood components, which can break down von Willebrand's factor and ultimately interfere with normal hemostasis. The treatment for AS relies heavily on surgical intervention. This is because medical therapies have proven ineffective at slowing disease progression or improving hemodynamics in severe AS. Statins have previously been studied in hopes that they may alter disease progression and prevent severe AS from developing, but such studies showed futility with statin use. Current guidelines recommend treating hypertension in these patients in an effort to reduce afterload and prevent additional workload on the left ventricle. However, it is imperative to exercise caution in using vasodilators in these patients because of their inability to increase cardiac output with decreases in systemic vascular resistance, which may potentially cause profound hypotension. The standard of care for patients with severe AS is replacement of the aortic valve. This has traditionally been limited to surgical replacement of the aortic valve, but in recent years, transcatheter valve replacement technologies have provided a less invasive approach for aortic valve replacement. Ongoing research is being done to identify which patients receive the greatest benefit from these transcatheter technologies. That concludes our discussion on the pathophysiology of AS. Thank you for viewing this video. If you have future tutorials or videos that you would like to see, please let us know on Twitter at @atriumrx.